Good afternoon, everyone. My name is Orbán Sándor, and let me show you some new insight on the treatment of metastatic gastroenteropancreatic neuroendocrine tumors. I think everyone here in the room agrees that radioligand therapy is a super efficient treatment option for metastatic gastroenteropancreatic neuroendocrine tumors. But it can be further improved as an integrated part of a multimodal approach, because still 31% of patients undergoing radioligand monotherapy die within 5 years. Our systematic review and meta-analysis provides clear evidence that primary tumor resection prior to radioligand therapy significantly elevates the relative risk, decreases the relative risk of mortality for these patients. It has to be noted that our research is based on mostly retrospective studies, and selection bias needs to be accounted for. And of course, future randomized controlled trials are crucially needed to elevate the evidence level. I'm a medical doctor and a first-year PhD student, and my vision is to advance the treatment of gastroenteropancreatic neuroendocrine tumors, improving survival and quality of life. And my mission is to find the best combination and sequence of treatment modalities for these patients. I have 2 ongoing projects. The first one will be conducted via meta-analysis, and the second one will be conducted via SEER Registry Analysis. So neuroendocrine tumors are rare malignancies rising in incidence and prevalence. Most of them originate from the gastroenteropancreatic tract. Most of them will be metastatic already at the presentation. Being a systematic disease, they require systemic medical treatment. However, recent clinical studies suggest that primary tumor resection in metastatic GEP-NETs could prolong survival. So the first project investigating the effect of primary tumor resection prior to PRRT in metastatic GEP-NET patients. Most of the GEP-NETs will overexpress somatostatin receptors, which can be targeted via somatostatin analogs or via PRRT. What is PRRT? It's a targeted radiotherapy in which a radionuclide is bound to a drug octreotide, which targets the somatostatin 2 receptor, and the radiation from the radionuclide will cause the tumor to shrink. Some studies suggest that lower tumor burden is associated with better response to PRRT. So our question arises, is there a potential benefit of primary tumor resection prior to PRRT in stage 4 GEP-NET patients? So the population is metastatic GEP-NET patients. The intervention is combined therapy. The comparator group is PRRT alone, and the primary outcomes are progression-free survival and overall survival. Our hypothesis is primary tumor resection prior to PRRT indeed improves prognosis in stage 4 GEP-NET. Here you can see the search key used for the systematic search and the flowchart of selections. We started with around 6,000 articles, and we got down to 21. Here you can see the first forest plot with the progression-free survival as the analyzed outcome measured by hazard ratio. Hazard ratio below 1 means better progression-free survival with combined therapy, and above 1 means better progression-free survival with PRRT alone. And as you can see, we have 7 different populations from 4 different articles with around 900 patients with moderate heterogeneity, and the pooled hazard ratio is 0.66, which means that we have 34 relative percent better chance for progression-free survival for patients undergoing the combined therapy. This is This finding is clinically highly relevant and mathematically significant. The second forest plot shows us the overall survival also measured by hazard ratio. We have 6 different populations from 3 different articles with low to moderate heterogeneity. Here you can see 0.43 pooled hazard ratio, which means 57% better chance for overall survival in the combined therapy group. This is clinically highly relevant and mathematically significant. Our conclusion is that primary tumor resection before PRRT provides a clear survival advantage. The implication for practice could be primary tumor resection before PRRT should be considered for well-selected stage 4 gastroenteropancreatic neuroendocrine tumor patients. The implication for research could be prospective randomized clinical trials are crucially needed with subgroup analysis for different primary tumor groups and grades, with standardized quality of life assessment also necessary. The strengths of our study could be there has been no summarized information available until now about primary tumor resection prior to PRRT. We have conclusive clinically relevant results, and it was conducted via a robust methodology. The limitations could be the few available studies and most of them being retrospective in nature. We finished the manuscript writing. Currently, we have only a few final refinements before submitting for internal review. The second project is about investigating the safety and effectiveness of surgical excision of primary tumor in well-differentiated metastatic pancreatic neuroendocrine tumors. So PNETs are rare neoplasms. They account 1% by incidence and 10% by prevalence of all pancreatic cancers. So the question also arises, is there a potential benefit for primary tumor resection in metastatic well-differentiated pancreatic neuroendocrine tumors? The population is well-differentiated grade 1, grade 2 metastatic pancreatic neuroendocrine tumors. The interventions are the surgical excision of the primary tumor or ablation of the primary tumor, and the comparator group received only systematic treatments. The primary outcome we are looking for is overall survival, and our hypothesis is that in patients with metastatic well-differentiated PNET, surgical removal of the primary tumor improves overall survival and disease control compared to medical therapies. The clinical implication could be improved patient outcome, survival, or even cure of the disease. It will be conducted via SEER Registry Analysis. The SEER Registry is maintained by the National Cancer Institute. It provides data on cancer incidence, prevalence, survival, and mortality. We gained access to the database via the SEER-STAT application. Currently, we are at the patient selection group, and we have around 2,000 patients enrolled in the intervention group. So as a summary, the first project is at the manuscript writing phase. The planned submission date is September this year, and the second project is at the data cleaning phase or patient selection phase, and it will be submitted around June next year. And let me finish my presentation with the words of Carl Sagan: somewhere something incredible is waiting to be known. Thank you for your attention.
Why did you take apart the study of Kramer or someone who did it 3 ways? So you said we've got results from 4 studies and there are 7 subgroups. So could you have not done it altogether? What was the reason?
Thank you for your question. Actually, they didn't report the hazard ratios together for all GapNets. And the other problem with the Kramer article that they included also lung neuroendocrine tumors, and we had to exclude them. But luckily, they reported the hazard ratios separately for all primary sites. That's why we decided to put it separately. So in this way, we can see also the primary sites, and we can see that although heterogeneity and different tumor sites, the results are clear. And yeah, sure. Overall survival or progression-free survival?
Either or.
Yeah.
So do you think that pancreatic cancer patients, pancreatic NET patients have the most benefit, or do you think it's early to say? Because you see the largest effect in pancreas and the least in colorectal and duodenum stomach.
Yeah, thank you for your question. It is very interesting, and it has to be noted that it's surprising that actually pancreatic surgeries did so well in this analysis, because usually when we think about primary tumor resections, it is in a case of a small intestinal primary tumor. But in this analysis, and also Bertani and Kramer proved that we have to think about this option also in the case of pancreas, because we have surprisingly good results with the pancreas primary tumor resection also.
So today I found a patient at the MDT who has got a pancreatic NET and possibly a liver metastasis, a single one. So no, it's an oligometastatic disease. What would you suggest as a treatment for him or her?
Of course, there are criteria for operability also. But if the surgical team deems the primary tumor operable, I would definitely push towards that way the patient for the surgery team. With the primary tumor resected, we have multiple possibilities for other treatment options. And what is very interesting, that primary tumor resection also enhances other treatment options like PRRT, or we could also use TASE for this patient with single liver metastasis in hopefully in one sitting. It can be even be done.
The first question is absolutely a practical aspect. So, as you mentioned previously, with a single liver metastasis, and you remove the primary tumor and the liver metastasis in one stage.
Yeah,
is there any indication for PRRT after that?
Yeah, thank you for your question. I completely forgot about metastectomy. You are absolutely right. The newest articles suggest a criterion for these cases. Based on the size and number of liver metastases, we have 4 categories. The type 1 category, where there is only single liver metastasis in a good location, it is recommended to take the metastasis out in a synchronous fashion with the primary tumor. The second category is about when you cannot do it synchronously. You can give somatostatin analogs or TATSE for the liver metastasis, or PRRT. And the third category is also a little bit more complicated, where 70% cytoreduction cannot be achieved in the liver debulking surgery. And the fourth category is where only palliative options are available. So yeah, you are absolutely right. In a single liver metastasis, synchronous metastectomy and primary tumor resection is achievable and very highly effective.
And the second one regarding the pancreas, this nice results. So It is a retrospective design. Is there any selection bias? Because we don't know who died after the operation or has a progression after pancreatic surgery. Because if we compare these organs, so the pancreatic surgery is the biggest one.
Yeah, you are absolutely right. We have to account for selection bias also. But luckily, Bertani et al. Is the single article which did the research in a prospective fashion. So the results regarding pancreas from Bertani are a little bit more reliable.